Welcome. In this module, we are going to discuss about the heterotaxy syndromes. Heterotaxy syndromes are caused by failure of differentiation into right and left-sided organs, resulting in congenital malformations of multiple visceral organ systems as well as the cardiovascular system. Right isomerism, also called as Asplenia syndrome or IV mark syndrome, is associated with the absence of spleen, which is a left-sided organ, and has got a tendency for bilateral right-sidedness. The other variant, Polysplenia syndrome, which is the left atrial isomerism, will be associated with multiple splenic tissues and a tendency for bilateral left-sidedness. Asplenia and polysplenia are associated with certain peculiar abnormalities. In superior vena cava, 2/3 of asplenics will have bilateral superior vena cava. However, more polysplenics will have a single superior vena cava. Inferior vena cava will be patent in all the patients with asplenia, sometimes may be left-sided in about 1/3 of the patients. IVC will often be interrupted with an azygous continuation in polysplenia. When it comes to the position of inferior vena cava and abdominal aorta, we will notice that in most of the asplenics, the inferior vena cava and aorta will be on the same side, or in other words, juxtaposition of the IVC and abdominal aorta. However, this is very, very rare in polysplenia. All the hepatic veins in asplenia converge towards the inferior vena cava before the inferior vena cavo-atrial junction. In polysplenics, since the IVC is interrupted and continues as azygous continuation, all the hepatic veins directly drain into the atria. In the atrial septum, large atrial septal defects, primum atrial septal defects, and common atrium are very, very common in asplenia and almost seen in everybody. Most of the polysplenics will also have atrial septal defects. Pulmonary veins may be abnormally be draining in about 80% of total of asplenic syndromes, and all of them will be either supracardiac or infracardiac. This extracardiac TAPVC is not common in polysplenia at all. Polysplenia will have normal pulmonary venous drainage in half of the patients, and half of them may have partial or hemi-anomalous pulmonary venous connection, and it is almost always cardiac. Coronary sinus may be absent in both. Asplenic syndrome may have bilateral sinus node, whereas polysplenic syndrome will have an ectopic low coronary sinus rhythm. Atrioventricular valve is almost always common in asplenics, whereas almost about 50% of the polysplenics will have two separate AV valves. Single ventricle is more common in asplenia. Asplenia as well as polysplenia may be associated either with levocardia or dextrocardia. The great artery relationship is mostly abnormal in asplenia, whereas mostly normal in polysplenia. It's easy to remember the table if you are seeing all the different morphological variations of heterotaxy syndromes. Hepatic veins drain into the inferior vena cava in most patients with right isomerism. In polysplenia, the hepatic veins directly drain into the atria, whereas in right isomerism, always the hepatic veins drain into the inferior vena cava. Inferior vena cava and abdominal aorta are on the same side of the spine in asplenics. You can appreciate in this subxiphoid coronal view, both the inferior vena cava and the abdominal aorta are on the left side of the spine. The inferior vena cava is anterior to the abdominal aorta, and the abdominal aorta takes a systolic flashing red color. The liver is in midline. Bilateral superior vena cava is more common in asplenics. You can appreciate from the suprasternal view that there are two superior vena cava on either side of the great arteries. You can also notice a thymic tissue in close relation to the great arteries. Heterotaxy syndromes are not commonly associated with thymic hyperplasia. The flow of blood through the right superior vena cava is shown in this coronal view from suprasternal echo window. Similarly, the flow from the left superior vena cava directly onto the left-sided atrium without any roofing of the coronary sinus is seen. Coronary sinus is an integral part of the left atrium. So whenever there is right isomerism, there is bilateral right-sidedness, and so coronary sinus is often absent. You can appreciate the left superior vena cava directly draining into the roof of the left atrium without any formation of the coronary sinus. It is important to recognize that there is no coronary sinus in this parasternal short axis view. Coronary sinus is extremely uncommon to be seen in an splenic heart. Total anomalous pulmonary venous connections are seen in almost about 80% of patients with asplenia. In all the patients, it's almost always supracardiac or infracardiac. In this subxified short axis view, we can appreciate a supracardiac TAPVC into the right superior vena cava going through a right vertical vein. There is a turbulence in the pathway of the pulmonary veins as it ascends up as the right vertical vein, and this is a feature of pulmonary venous obstruction. A good number of TAPVCs in association with asplenia will have obstruction to the pulmonary venous pathway. This is a suprasternal view showing a right vertical vein and entry of the pulmonary venous common chamber through a right vertical vein into the right superior vena cava. Contrary to the previous example, here there is no obstruction to the pulmonary venous pathway. We can appreciate the right vertical vein draining into the right superior vena cava. We have to understand that always asplenics will have either a supracardiac or infracardiac TAPVC, and the TAPVC is never within the heart, intracardiac. In this suprasternal view, initially we can see the right pulmonary artery. On a posterior sweep, we can appreciate the pulmonary veins converging to form a common chamber, and the common chamber forms a small ascending vein which drains into the right superior vena cava. Many of the TAPVCs associated with asplenia may be unobstructed, but about 2/5 of them may have obstruction. Dextrocardia can be seen in about 40% of patients with right and left isomerism. In this subxified view, we can appreciate that the cardiac apex is pointing towards the right side. Right isomerism is associated with bilateral large right-sided atrial appendages which are triangular. We can notice the left-sided atrium also having a large triangular atrial appendage. The mouth of the left-sided atrial appendage is very close to the left superior vena cava, and the left superior vena cava is draining without any coronary sinus directly into the roof of the left-sided atrium. Complete AV septal defects are more common in right isomerism than in left isomerism. We can see here an unbalanced AV septal defect, a very hypoplastic left ventricle, a free-floating bridging leaflet, large primum, and an additional large secondum atrial septal defect, almost amounting to common atrium. Single ventricle or univentricular heart is more common with right isomerism. Many left isomerism patients will have a biventricular heart. 80% of patients with right isomerism may have associated pulmonary stenosis or pulmonary atresia. We can appreciate in this subxified coronal view a malpost great artery, a right and anterior large aorta, a left and posterior small pulmonary artery with a subvalvar and valvar pulmonary stenosis which causes a systolic turbulence in the pulmonary outflow tract. A high parasternal short axis view shows the malpost great arteries. Here in this instance, the aorta is left and anterior, pulmonary artery is right and posterior, and we can see the large dilated pulmonary artery bifurcating into right and left pulmonary arteries. We can also appreciate that there is no obstruction to the pathway in the pulmonary outflow tract. In this high parasternal view, we can appreciate a normal thymic tissue. As we stressed earlier, Catch-22 mutations are associated with conotruncal abnormalities and not with the asplenia or polysplenia heterotaxis. We can notice the left and anterior aorta, right and posterior PA. These malpositions are more common with asplenia than with polysplenia. You can also notice bilateral superior vena cava on either sides of the great arteries. Bilateral superior vena cava again is seen in almost 2/3 of patients with asplenia, whereas only in 1/3 of patients with polysplenia. Polysplenia or left isomerism is associated with interruption of the inferior vena cava in almost all the patients. Partial anomalous pulmonary venous connections or total anomalous pulmonary venous connections are not very common as in asplenia. On a subxiphoid coronal sweep, we can appreciate the abnormal visceral position. The stomach is seen on the left side and the liver is in midline. We can also appreciate the aorta and the azygos on the same right side of the spine. The venous channel is not anterior to the aorta but is posterior to the aorta in the paravertebral gutter, indicating that the inferior vena cava is interrupted and continues as azygos vein. Liver in the midline is the common feature of both asplenia and polysplenia syndrome. On the subxiphoid view, inferior vena cava should always be anterior to the abdominal aorta. However, if the venous channel is seen posterior to the abdominal aorta, it's an indicator that the inferior vena cava is interrupted and the IVC in the infrahepatic region is continuing as azygos vein. On a color flow Doppler, we can appreciate the systolic pulsatility of the aorta and the venous flows in the azygos channel. The hepatic veins directly drain into the atria since the inferior vena cava is interrupted. On a long axial sagittal sweep, in the subxiphoid view, we can appreciate the long venous channel in the right paravertebral gutter, which represents the azygos continuation of the inferior vena cava. The other parallel longitudinal channel which has got a systolic pulsatile flow is the abdominal aorta. Since the hepatic segment of the inferior vena cava is interrupted, IVC continues as azygos vein, courses in the right paravertebral or left paravertebral gutter, and drains into the respective superior vena cava above the level of the hilum of the lungs. On a color flow Doppler interrogation, we can appreciate the venous flows in the azygos vein and the azygos drainage into the right superior vena cava. Since the flow in the azygos is from below upwards, it takes a blue color on the subxiphoid short axis view. The azygos continuation into the right superior vena cava, the course of the azygos in the right paravertebral gutter, and its anterior turning over to enter the posterior wall of the right superior vena cava is shown in this color compare mode from subxiphoid short axis view. Presence of bilateral superior vena cava is rare in polysplenia syndrome, is seen only in about 1/3 of the patients. Whenever there is a left superior vena cava in a polysplenia, they may be draining through a coronary sinus into the right atrium or may drain directly into the left atrium without a roofing of the coronary sinus. While the previous high parasternal short axis view showed a left superior vena cava draining through a roofed coronary sinus into the right atrium. In this instance, we can appreciate the left superior vena cava directly draining into the left atrium. We can also notice a small finger-shaped appendage on the left superior vena cava left atrial junction. Both the appendages are shaped similar like a left atrial appendage in left isomerism. On a subxiphoid coronal view, we can appreciate both the superior vena cava draining into the respective atria. The left superior vena cava does not form a coronary sinus and directly drains into the left atrial roof. On a color flow Doppler interrogation from the subxiphoid view, we can appreciate the flows in both the superior vena cava into the respective atria. On this modified apical view, we can notice a biventricular heart. The right pulmonary veins drain into the right atrium and left pulmonary veins drain into the left atrium. This intracardiac hemianomalous pulmonary venous connections are more common in the polysplenia syndrome. Whenever there is an abnormal pulmonary venous connection in polysplenia, it's almost always intracardiac. An extracardiac TAPVC is extremely rare in polysplenia syndrome. On the contrary, extracardiac TAPVCs are seen in almost about 80% of patients with asplenia syndrome. On the subxiphoid coronal view, we can appreciate both the pulmonary veins draining into the respective atria. On a high parasternal short axis view, we can again appreciate the pulmonary veins from either side draining into the respective atria. The color flow Doppler confirms the flow of the pulmonary veins from left side into the left atrium and right side into the right atrium. Anomalous pulmonary venous drainage is often partial in polysplenic syndrome and is almost always intracardiac. Presence of two ventricles is more common in polysplenia than in asplenia syndrome. We can appreciate in this modified subxiphoid long axis view that there are two well-formed ventricles. There is a large ventricular septal defect. However, there are two separate well-formed AV valves. These biventricular hearts are more common in the polysplenics. Pulmonary atresia or pulmonary stenosis is rare in polysplenia compared to asplenia. In this patient, we can notice that there is a pulmonary atresia with a left and anterior aorta and right and posterior pulmonary artery. Malposition of great arteries also is not very common in polysplenics. Normal relationship of the great arteries is more common in the polysplenics. In this subxiphoid coronal view, we can appreciate the normal relationship of the great arteries, aorta coming off the left ventricle and the pulmonary artery coming off the right ventricle with a normal crossover. On a subxiphoid short axis view, we can again notice the normal crossover of the right ventricular outflow tract around the aortic root. We need to understand that two ventricles are more common in polysplenia and is extremely uncommon in asplenic syndromes. Sometimes polysplenia may be associated with a univentricular heart. This is an example of a complete AV septal defect, unbalanced with a hypoplastic left side and a large right ventricle, a free-floating bridging leaflet in association with large primum and secondum atrial septal defects. To summarize, heterotaxy should be suspected whenever the visceral positions are not lateralized. If you are going to see a midline liver or the stomach in an abnormal position as in the right side, we should think about heterotaxy. Similarly, in any cardiac malposition as dextrocardia, we should suspect whether there can be a heterotaxy. Identifying the inferior vena cava will provide the initial clue towards the type of heterotaxy. In all patients with heterotaxy, we need to look for abnormal pulmonary venous connection. It's very common. Abnormal pulmonary venous connections are often extracardiac in asplenia and intracardiac in polysplenia. Most asplenic hearts are univentricular, but many polysplenic hearts may be biventricular.